Hello, I'm Rob Lott, Deputy Editor at Health Affairs, and I want to thank you for joining us for the latest in our series of Lunch and Learn discussions. Today, we are focusing on population health's next big question. In a moment, we'll hear from the experts, but I can say for now that we are starting at the beginning with the foundational idea at the center of the field of population health, the idea that there is an optimal balance of investments in multiple determinants of health, determinants like the environment, people's behavior, their socioeconomic status, and yes, the medical care they have access to and receive. In theory, that optimal balance of investments, if we get it right, will maximize overall health outcomes and minimize health inequities at the population level. This is the premise of a recent Health Affairs Forefront article by two of our guests today, David Kindig and John Mullahy, who ask, why is it so hard to develop that so-called population health fantasy equation, the equation that might allow us to define the optimal balance of investment with any precision? So we've asked David and John to join us today to solve all of our problems by answering this question once and for all. But if that's too much to ask, perhaps they can start by telling us why it's so hard to answer, or whether that's even the right question. Now, before we go any further, a few logistics. In a moment, I will introduce our speakers. David and John will begin, and then we'll bring in Sani to offer perhaps another perspective. And then from there, we'll have a conversation and some questions from me and all of you out there. You can submit questions at any time during today's event using the Q&A box through Zoom. We will try to get to as many as time allows and focus on topics that are of interest to the most people. As with other health affairs events, this session is being recorded and the video will be posted to healthaffairs.org in the coming days. Now, I am honored to introduce our guests. Dave Kindig is Emeritus Professor of Population Health Sciences and Emeritus Vice Chancellor for Health Sciences at the University of Wisconsin-Madison School of Medicine. He was founding co-chair of the Institute of Medicine Roundtable on Population Health Improvement, and he was an initial co-PI on the Robert Wood Johnson Match Grant, under which the county health rankings were developed. John Mullahy is Professor of Health Economics in the Department of Population Health Sciences, Affiliate Professor at the La Follette School of Public Affairs, and co-director of the NIMH training program in Health and Mental Health Economics, all at the University of Wisconsin-Madison. Professor Mullahy is also an honorary professor of economics at NUI Galway and research associate at the National Bureau of Economic Research. Sani Magnan was co-chair of the Roundtable on Population Health Improvement and is current co-chair of the Healthcare Expenditure Collaborative, both at the National Academies of Sciences, Engineering, and Medicine. She is a senior fellow at the Health Partners Institute and served as the Minnesota Commissioner of Health from 2008 to 2010. Thank you all for joining us. And with that, I will turn things over to Dave.
Well, Rob, thanks so much for having us, for setting up the conversation. In general, Sani and John are two of my closest colleagues and friends, and I consider you a friend too. So this is kind of a fun thing to do. And actually, congratulations on the new Forefront sort of platform. It's really snappy, and I've been following it on Twitter, and so that's a great thing that you guys are doing again. So the title mentions the fantasy equation. So that's shorthand that I've been using for years to refer to the classic article by Bob Evans and Greg Stoddard, which the model of which was reproduced in the Forefront article, if you've taken a look at that. I was privileged in the 1980s to spend a few times with the Canadian Population Health Study Group and got to know them and saw this article article, saw their classic article in draft. I was reviewing it and actually teaching from it before it was actually published in 1990. That paper and that article were my population health epiphany, with the basic message that you just put forward, that health requires more than medical care, including multiple determinants of health. And at the time, in 1990, the social determinants of health were really not appreciated outside of narrow academic and public health circles. So, that was a big deal. And actually their chapter, I remember being shamed as a former pediatrician, reading some of those papers and having gone to school by economists on what actually produces health. So that model gained gradual attention. But in a 2006 publication, Greg Stoddard, he actually called it the fantasy equation, in which he said, so I'm going to read that. At present, we vaguely understand the relative magnitude of the coefficients on the independent variables that would inform specific policies rather than broad directions, even if we are beginning to see the variables themselves more clearly. So that's his concept of a fantasy and the challenges behind it. And he actually added the sentence, which you picked up. I didn't know you were going to use it for the title of this talk. And most students of population health cannot confidently answer with precision the question, where would you put the money? And you didn't italicize it in your introduction to this talk. He said, where would you put the money? Which is actually sort of what we're about here today, all of us. So at the same time, right in 2007, not being deterred by all this pessimism, the final sentence of a paper I wrote in Milbank called Understanding Population Health Terminology, 2007, it actually ended with the quote that you actually read, the quote that I guess I won't repeat right now. What is the population health question? And I think that continues to today. What is the balance of determinants that produces the outcomes, including reducing disparities that we want to achieve? And actually, I added it's a significant challenge that will require decades of attention by scholars and policymakers. And here we are, right, in 2022. So fast forward to all that. Last year, John invited me in the midst of COVID, and I was feeling a little isolated at home. He invited me to do some guest lectures in his intro to population health course. I decided to talk about, I don't have to do the what is population health thing anymore, or what are social determinants. People kind of come in knowing it. And but anyway, I was doing it later on in the course on investment, pop health investments and policies. And again, setting up with the Evans Stoddard model to his class. And I said to the class, why are we not further along in sort of answering this question from, they wrote the paper in probably 1988. It didn't get published till 1990, and in the book in 1994. So anyway, and then I said, can this be as hard as the equations needed to land on the moon? And so we got a little, I didn't plan this part of the class. We sort of kind of happened spontaneously. So I said, well, let's spend a little time on this. So I went to the whiteboard and we began to make a list with John. I said, John, you're not off the hook. You got to help. But the students were going at it as well. And we developed this list of challenges that we discuss in the paper. And I'm not going into the depth that you can take a look at that if you haven't read the article. But the categories were social science is harder regarding having to determine these kind of causal relationships. There are many different outcomes that we might be interested in. There are multiple units of analysis that we might be thinking about: individuals, communities, nations, counties, the world. There are many, many, many complex empirical issues for which my colleague here is much more the expert than I, but we list them there. And then lots of data limitations. And so, we developed that, and then John and I spent a little bit on time on it after the class, getting ready to write the paper. And then at the end of the discussion, the majority of students agreed that the moon landing was less complicated. And of course, this is empirically correct because we have landed on the moon, but we still do not have optimal health outcomes and have not resolved the terrible inequities and the extraordinary costs that are in our system. However, I continue to refuse to accept a policy scenario in which investment decisions are set on guesses, hunches, political whims, opinions. That can't be the way that we're going to improve population health. So where does this leave this? I turn to my favorite economist who always gets the really hard questions. John?
Thanks, Dave. I've known Dave for 25 years, and without exception, I can say that I always learn something when I hear him make presentations long and short. So thanks for those remarks. In the 30 plus years since Evans and Stoddard's paper came out, a lot has changed in the real world and in the scholarly world. And the one thing I'd like to emphasize in the couple minutes that I'm going to talk is basically what Dave hinted at the end. How is it that we go about thinking about evidence to inform policy? And I'm just going to read a very brief excerpt from a paper that I assigned to pretty much all my classes. Not a health affairs paper, Rob, but still a very credible paper by Kate Baker and Amitabh Chandra that appeared in the New England Journal of Medicine a few years ago, titled Evidence-Based Health Policy. Evidence-based health policy requires evidence of the magnitude of the effects of the policy. And obtaining such evidence is an inherently empirical endeavor. Introspection and theory are terrible ways to evaluate policy. Just because something sounds true doesn't mean that it is, and magical thinking won't improve our healthcare system. I would argue more broadly, our health system, quite broadly read. Evidence-based health policy helps separate facts from aspiration. And I want to just speak to the nature of evidence and how I think in the 32 years since Evans and Stoddard, the thinking in our empirical sciences about evidence has evolved in what I would argue to be very productive ways. The people who do quantitative social science, quantitative epidemiology, quantitative clinical sciences, the methods and the mindsets that we approach our problems with have in many ways synthesized. We can talk across disciplines in ways that I think 30 years would have been very challenging with respect to methods and data. But also in so far as how seriously we take evidence and how we, in some sense, evaluate evidence. I just want to quickly list 6 points, I think, to put out there for consideration. So the first one, do the findings that we're relying on insofar as policy formulation, do they appear in peer-reviewed scholarly literatures? Just because they do doesn't mean they are great, and even if they don't, doesn't mean they can't be informative. I think we have to think very seriously about what are the sources we turn to for the evidence that we use. The second point is the scholarly literature that we turn to subject to what's known as positive publication bias? Are the findings that show that things work more likely to appear in the literature than the findings that show things don't work? And I think we have to be attentive to that potential bias. The third point, and Dave hinted at this, is do the reported findings plausibly speak to causal relationships? And there's been an enormous advance in thinking about how we can assess those questions. Still a very tough problem. The fourth is, are the reported findings sturdy, or do they depend on what we might think of as fragile assumptions? We would like evidence that we draw from whatever source to be robust to all sorts of possible problems that might arise. The fifth one is, do the specific interventions and outcomes that are being studied in the scholarly literature correspond well to the interventions and outcomes that are on the policy plate. Sometimes, this kind of tax might look like a different kind of tax, but may, in terms of its implementation, be very different. So how well do the things that have been studied correspond to the things that are relevant in the policy formulation context? And then lastly, the old adage that the absence of evidence does not equal the evidence of absence. And taking seriously, if we're going to be doing hypothesis testing or some other form of inference, taking seriously the idea of the costs of the mistakes that we might make in our inference is something that I think still can be problematic, that we don't do often enough. Is it better to sort of err on the side of caution? Is it better to err on the side of aggressiveness? Those are parts of the inferential process that I think require attention that sometimes isn't adequately devoted. So let me stop with that and turn it back to Rob for a second, and then I think over to Sandy.
Sorry about that. Thank you, John. Thank you, David. With that, we'll turn things over to Sandy, who may be able to offer some additional perspective.
Thank you, Dave, John, and Rob, for thought-provoking health affairs forefront piece, as well as your comments, Dave and John, that you just made. Before I get in my reflections, one framing remark: the US spends the most of any country, developed country in the world, per capita on healthcare, and yet we do not have outcomes that reflect that kind of investment for a developed country, including we have decreasing life expectancy. So given that backdrop, I have three reflections to make. First, I agree that we should move from determinant benchmarks to investment benchmarks, including equity and investments. Dave, that reflects your article in Preventing Chronic Disease that you did a number of years ago. Recently, Brookings had a report that I think reflects where I would put the money. And the report was titled Rebalancing Children First. So two cautions I would have about thinking in terms of changing investments. First is we should never underestimate the status quo. Every bit of current investment is someone's income. The second thing is that as we think about healthcare's interest in the social determinants of health, there's a lot of enthusiasm for healthcare's interest in the social determinants of health. And I applaud that, but I say there's also a danger that we can medicalize the social determinants of health. My second reflection would be, in the article you said that a next step would be to talk to policymakers about what information they need around population health. And I think that's good, but I would go further. I see that as giving them technical information. And I think in order to change investments, they also need adaptive skills. This kind of reflects HIFIT's technical and adaptive leadership. And an example would be what Kansas did with their Kansas Legislative Health Academy. They know that changing or implementing health policy often elicits controversy. So they created not only the ability to give legislators information, but also gave them information about the ethics of health policy. How do values contribute to the context of creating health policy? Gave them information about thinking of civic leadership. How do you engage with people who have differing political opinions? And they created spaces and locations and structures for constructive conversation. So they created technical and adaptive leadership frameworks for policymakers in Kansas. The last thing I would say in this second reflection is that policymakers also need grassroots activism and support from their constituents. And I remember when I was Commissioner of Health, that a legislator leaned over to me and said, as we were contemplating a policy to invest 50 million in tobacco control and obesity prevention efforts, he leaned over and said, "Can you get my constituents calling me about this?" So we need to think about how do we create movements around these changing investments for population health. And then the last reflection I would make is, let's not have perfection be the enemy of good. I appreciate what John just had to say about questions that we should consider as we think about evidence. And certainly we should be doing that. And I appreciate that framework. I also appreciate organizations like county-based health rankings and roadmaps that have hundreds of policies that organizations and individuals can look at how they might apply to their counties and their locales with that. And they also have skills and tools for how do you create equitable outcomes as you implement policies. So the last thing I would quote, and it's that if we don't change these investments, we can't really expect anything different. If we don't solve this fantasy equation to have something different, there are going to be dire consequences. And here I will quote Evans and Stoddard again, who's been referenced a number of times. They said, "A society that spends so much on healthcare that it cannot or will not spend adequately on other health enhancing activities may actually be reducing the health of its population." So thank you very much.
Wonderful, Sandy. Thank you for your thoughts. Just a reminder to our listeners that you can submit questions at any time during the event using the Q&A box through Zoom, and we'll try to get to as many of those as possible. I'll start with a question, and it might be to undermine our very premise here today. I realize it may not be fair to all of you, since it was me and my colleagues at Health Affairs who framed this session around the question, where would you put the money? But I will ask anyway, how much of this conversation is actually about dollars and cents and budget and the role of appropriators? And to what extent is money a proxy for sort of broader priorities and values? How much depends on dollars and cents? How much depends on things like organization, infrastructure, and leadership?
Yeah, so that's a great question. It's fair. Yeah, I've been accused of often only talking about financial incentives, you know, as opposed to all the other kinds of incentives. Actually, I've written about some of that with George Isham, but I don't know. I mean, I came of age in an OEO neighborhood health center in the South Bronx. And that was a time, I mean, I didn't know what the social determinants of health were, but it was innovative medical care in a tough setting. But OEO, because of its, actually, I mean, they had a population health framework before anybody called it that in the Johnson War on Poverty. I mean, in that health center, I mean, we did school health and job training and legal advocacy and outreach. So, but it was the funding, but there was funding that paid for that. You know, and even in the best neighborhood health centers that remain today in what's a really important program, you know, there aren't the resources to do that. And so many of them don't have such a robust programs as back then. When I ran Montefiore Hospital in the Bronx, which was quite an experience for me, younger than I should have been. I mean, I remember the specifics of the graduate medical education funding formula, where $1 comes in every day for every resident, no matter what, in arcane ways, you know, probably more than is deserved, I would say. So I guess I've been really impressed in my whole career about the power of those financial incentives. Now you have to have other things going with them, as you hinted, either to get them or to keep them being sustained. But I agree with Sandy. I would like to, so the county health rankings has benchmarks in every county for what the determinants should be at the 90% level, like smoking rates, like uninsured or whatever. There ought to be a little thing up there is what's the per capita investment in that community, in each of those determinants that are needed to sort of move the needle as best we understand those causal relationships, which we don't fully understand yet. So the fantasy equation isn't a goal in its own right. It's a means to an end to give people guidance about how to do that. And then, of course, you know, evidence does not make policy. I mean, we all know that. I mean, I for one, I mean, if there's an evidence-based thing that we understand from fairly serious Nobel laureate kind of work, it's the value of early childhood education and the failure. And actually, I think the fact that there was that empiric base is why it got so far in Build Back Better. But what a disappointment and a shame that even that evidence could not get that, at least yet, over that hurdle. So I think I maybe didn't fully answer your question about other determinants, but it's not all about the money, but those are really super powerful incentives in our current economy.
Great, and
John?
thank you. That's great for teeing things up. I do want to point to a question from our audience that I think you attempted to answer. One of the viewers asked Sandy if she could clarify moving from determinant benchmarks to investment benchmarks, including equity, maybe an example. And Dave sort of suggested what that might look like in the county health rankings. Is that how you're envisioning it, Sandy, or what do you have in mind?
Yeah. So what the coefficient should be and how those investment benchmarks should be set, like county-based health rankings, I think we still have to determine. But let me give you an example of where I think when I was Commissioner of Health, we didn't set an equity benchmark. And so we implemented a policy for dental therapists to actually be able to increase dental access for lower socioeconomic populations in Minnesota. And so we implemented that policy. Of course, it took a while to train the dental therapists, get them into the field, but we had said, okay, we want them to be in places that have communities that have 50% or greater Medicaid population and have homeless populations. So we made an attempt to say, let's go for populations that we know will have greater disparities. And yet, when the evaluation was done, we did increase dental access in lower socioeconomic populations, but we did not, erase the racial and ethnic disparities. Now, if we had set benchmarks around that and had actually thought about how we would invest differently with those dental therapists, could we have gotten a different outcome?
Let me just add, I appreciate the plug for that paper, Sandy, and actually it's one of my favorite little papers that very few people have ever read. It is in Preventing Chronic Disease, called From Investment Benchmarks, Determinant Benchmarks to Investment Benchmarks. But that, I think we briefly mentioned equity, but not at all to the extent that we would include that in that thinking, today. I mean, that's much more cutting edge aspects of that.
If I just might add on top of that, though, that I think the idea, if the world is value-based in everything it does to some extent, with creative innovations in embedding considerations of equity, disparity reduction, however one might want to characterize it, in the way that providers of healthcare get paid for doing what they do. And we're starting to see, I think, at least some baby steps in that direction. Then I think we start getting closer to the title of Dave's book back in 1997. We're purchasing population health, and we're purchasing population health in a marketplace that respects, supply and demand and what providers get paid for doing what they do. So if we can embed these considerations better in those kinds of mechanisms, I think we're more likely to be going in the right direction with our investments.
One of the things you have to really look out for, and even drifting into this conversation, we've been talking more about healthcare examples, and of course, it's not all about healthcare. That's what the pop health model is, but there's investments in other sectors, and multi-sectoral partnerships that might be required in order to, pull this off. Unfortunately, if population health is a multiple determinant production function, that's a little bit of econ speak, but I've learned from my friend here, if it's that kind of a production function, then it's a multi-sector collaboration. And that makes it even more complicated, sort of the balancing part. I mean, if you had investment benchmarks, well, from which sector does that per capita investment sort of come from? And that's a complicated, I used to think that possibly each sector could figure out its own piece of it, its own optimal piece of it, and it would sort of just happen, sort of come together. I don't believe that. I really do believe some of the multi-sectoral coordinating mechanisms, I used to call them health outcome trusts, but whatever. And there are little vestiges of that around the country in different kind of ways. The Robert Wood Johnson Culture of Health Prize actually has one criteria for the degree to which it's a rich multi-sectoral partnership across healthcare, public health, business, social services, whatever. Anyway, that's a part of it that it's not the fantasy equation, but it's maybe like what you were asking, Rob. It's more than just the dollars. It's sort of how do we organize for that kind of a complex investment mix.
And I would say we need to do it in a way that community-based organizations are taking the lead. Often in communities, it's healthcare. That's the largest organization. It's the predominant employer, has the most clout, so to speak. But to actually solve these issues, we need the community and community-based organizations to be taking the lead on how we essentially solve this fantasy equation and put the money in the right places.
And empirically, at least with the early experiences of the Culture of Health Prize, in some cases, innovative medical care organizations take the lead at the community level in being the glue organization. In other cases, it's innovative public health departments. In other cases, it's United Ways or other kinds of organizations. So at least, I haven't studied this recently, but I think today there's no answer yet as to at each community level, what's the best organization for providing that quarterback function. Maybe I digress a bit, but anyway, over to you, back to you, Rob.
Well, with that in mind, I think if on one hand, we sort of kind of agree that multi-sectoral approach is the way to go, and that different communities might be led by different organizations. And yet, I think it's also fair to say that the sort of medical model still kind of occupies a central place in our conversation about health. The sort of gravitational pull of health systems in a community is pretty undeniable. Is that an obstacle to sort of identifying the organization that's going to truly, take us to the next level, or is it just sort of a fact of nature that we need to accommodate and sort of build our approach around?
Well, Sandy and I have discussed this so many times. You want to start on this, Sandy, or?
I would say something I've written in a couple of papers is that healthcare needs to have humility. in how it thinks about its role within a community and how it listens to its community members. And I remember a CEO of a large healthcare system in a rural county in Minnesota, who said, we're going to meet with the community members, told his board this, and said, and we're not going to like what we hear. But he had the leadership courage to say, if we're actually going to change things here, we've got to listen to the community, and we may hear things, not what we want to hear, but it's what we need in order to take some next steps. That was leadership and humility. So,
I mean, I'd like to be hopeful about that. And I have no doubt that there are places where progressive medical organizations, healthcare organizations can take the lead. I'm afraid and like John says, there's movement towards value. But that, I don't believe that's been adequately incentivized enough to be the driver over much of what drives priorities within healthcare organizations. So having said that, there are not equal forces in other sectors either. So, I mean, I've sort of fantasized about, could we have some, so this is really going forward, but could we have some sort of a financial formula, like mortgage interest deduction or crop subsidies at that kind of a level, with population health outcomes and value as the base, to maybe go to a community level that everybody could then participate in, and it wouldn't privilege, one or the other. So it would make make a level playing field for multiple sectors and community levels to work together. Right now, I think it's the unusual healthcare organization that takes a true approach to this. I mean, think about community benefit. No, let's not go on a community benefit. That's a whole nother story. But
that's our next lunch and learn.
Seriously?
No, it could be. Well,
hey, I'm on for that one. Anyway,
Dave has written very thoughtfully over the years about, when we use the term population health, what are we talking about? And going back to Evans and Stoddard, the idea that population health might be a field of study, a field of inquiry, like we do here in our graduate programs, but it also speaks to the issue of, what do we mean by the health of populations? And even more recently, though, the idea that population health, the term population health, has tended to be applied quite broadly insofar as clinical or medical management of the health of populations. And that's not right or wrong, but it's a different orientation. And the reason I raise this point is because we've had discussions over the years of why can't these two, I'm going to use the word camps, and that's probably not a good way to characterize it. Why can't these two camps of population health thinking, get together and think about what it would mean for population health management in the clinical or medical context to be more concerned about the broader health of populations? Just one small example of how these happens, the physician and nephrologist who directs our accountable care organization here in our health plan was a graduate student in our population health program. He gets the idea of social determinants and multiple determinants of health, and he understands the way these two camps have to sit together in order to actually bring the power, the influence of the medical sector to bear on the broader issues of multi-sector investments in population health.
So, but that's terrific. And it's a real problem, because you can't be against, there's no way, it's a good thing that healthcare systems are beginning to think about some of these broader contexts and get involved. But it also can become totally medicalized, rather than the breadth of what the idea really is. Paula Lance has written very provocatively about the medicalization of population health. So it's both. It's hopeful, but it's also a challenge and a potential problem.
And one of the things, I mean, healthcare, we are so thankful to have really good healthcare. You know, as I think about a dear friend of mine is going in for a bypass surgery at this moment. So I'm really thankful that we have excellent healthcare, but it is very individually focused. And to think about populations, whether that be attributed populations in an ACO or a geographic population, is a new way of thinking. And I think the fact that we're even talking about it on this, you know, Lunch and Learn today is a start. And it wouldn't have happened 5-10 years ago. I don't think we'd be sitting here talking about that. So the other thing is we need to think differently about how we do pay and how, let's take it all the way up to the federal government. I know there were some colleagues of ours who were trying to get CMS to be able to pay for decreasing tobacco prevalence in a community, which would take it to the population level, which meant you had to think about policies, not just getting people Nicorette gum, individuals, but to take it to the policy level. And however, the current, the CBO, the Chief Budget Office, looking at that, it was really hard because what their laws say is it has to benefit individual Medicare beneficiaries. So to think about changing payment within CMS for a population level outcome was not something they had the parameters in which to do, even though it might greatly benefit Medicare beneficiaries. They didn't have the laws and the jurisdiction to be able to do that. So there's a lot we need to think about that needs to be changed in order to get to paying or purchasing population health.
Great. Let's turn to some audience questions. I have what is perhaps a technical question. They write, if the perfect equation hasn't been identified yet, could you say how much of the variance in population outcome has been reliably identified or agreed on in the field? And what are those relevant variables?
That you take that one.
Thanks. My ex-friend. You know, I'm not going to be able to tell you 0.01 or 0.95 or anything like that. I will say, if I was trying to think through that question with a bunch of students, I'd first say, well, what is the health outcome that you are trying to understand here? Is it mortality? Is it quality adjusted life years? Is it rates of chronic illness in a community? You know, some of those will, by their nature, be maybe a bit easier to get an empirical handle on than might others. Would we compound that analysis by also trying to consider the disparities in health that were existing in our data, in our reflecting our population? That might be an even more formidable empirical task. And you know, ultimately, and Dave hinted at this, and I hinted at this in my introductory remarks, you know, just the establishment, the documentation of correlations and associations, you know, that's instructive for thinking about certain questions, but it doesn't get us to the cause and effect considerations that are the ones that, you know, need to be at least an important part of the policy discussion. Maybe they can't be the entirety of it because of how challenging, but you know, just because I can say, oh, this equation explained 75% of the variance in some outcome that we agree is interesting, that's getting us part of the way there, but it doesn't get us to the question of, hey, will this policy work to improve the health of a defined population?
I was, as you mentioned in the beginning, I was one of the architects of the County Health Rankings program, and you know, in order to rank, we decided to rank as a powerful communication tool, for good or ill. It's got pluses and minuses, right? But in order to rank, you have to, if we're going to rank both on the factors as well as the outcomes, then you have to put coefficients on those factors. And I think a lot of people know, sort of the mantra that we have about that we come up on both somewhat empirically and somewhat expert opinion on the 20% from medical care, the 40% from social factors, et cetera, et cetera. I mean, those are pretty rough. They're pretty rough approximations. I mean, the best we could come up with at the time, and they gross over a little bit of John's thing about like, for example, which outcomes. I mean, for us, it's a bucket of outcomes of mortality and morbidity. But however, and the 20% in healthcare is the one that's gotten the most attention, for good or ill. And however right or wrong that is, before that, and in the model of Evans and Stoddard, before the model that we printed in the paper, it used to be that it was 100%, that disease is the outcome and healthcare is what takes care of it. That's pre-Evans and Stoddard and other thinking. And so as we evolve, that there are other things like the McGinnis paper, actual causes of death, his New England Journal paper that's had 5,000 views, that shows particularly about behaviors are probably a big part of the question. Oop, okay, so it's not 100% anymore, right? And so if nothing else, the fact that I'm really proud of the fact that we, with whatever warts it might have, that we called attention to the fact that it is not all about healthcare. It's bigger than that. But that's also puts into relief the fantasy equation. I think we really do need to know more precisely what are the exact investments required in the different sectors to do the kind of benchmarks that we need. Anyway. But there are, actually, I think we write in this forefront piece, whatever the issues with this fantasy equation that we've been talking about, and we outline paper, I believe there are still Nobel Prizes in medicine or economics to be won by getting closer to what the answer is, even if there's never a single perfect answer. So I want to encourage, if that was a student who put in that question, a PhD student, I'm going to say, go for it.
Great. Well, that tees up another question and one of my own. So the audience member wrote, how do we invest and teach our students about the intersectionality of community and healthcare organizations solving this equation? And how do we create buy-in across the various equations? And then I'll add my own thought. You framed your piece around David's lecture to John's class. And all three of you have been in this field for quite a while. What about or what questions or ideas have your students offered you recently that have maybe surprised you or that you wouldn't have predicted or expected 30 years ago?
Do you want to start?
Well, I'll start.
Okay, go ahead.
Yeah.
You've been teaching more recently. Yeah, no, please.
Well, I would say the one thing that has changed in a very rewarding way from my perspective, I'll let students decide if it's rewarding from their perspective, but certainly from my perspective, has been the span of disciplines represented by the students who show up in my classes. When I first came here in the late 1990s, I was mostly speaking with econ students and the early generations, the small early generations of our population health graduate students. But now when I teach a class, our introductory class or a health economics class or a measuring health class, I'm finding students not just from those disciplines, but from sociology, pharmacy, nursing, psychology, engineering. And by putting, and this I think speaks to the first part of your question, Rob, by putting these different perspectives and training foundations together in the same room, oftentimes the best thing I can do is just step back and let good things happen when they talk with each other from their perspectives. And because that kind of multidisciplinary scholarship is so valued in these parts, the ability of these different kinds of students with their different training to communicate with each other using a language that they, or maybe languages, but that they understand them mutually is, I think, a really exciting change over the last, at least 25 years that I've witnessed. So how that gets translated into improving population health, I don't know, but there's a real sense of energy that I think is running through those kinds of discussions that gives me a lot of hope and promise.
Yeah, and there's lots of stuff. I mean, I don't have a full landscape of what's going on across academia, but I mean, these ideas are now not uncommon in public health training, in multidisciplinary pop health training. There's a new, give a plug for the IAPHS, Interdisciplinary Association of Population Health Sciences. It's a relatively new nonprofit organization it's a homeroom. There's not a lot of homerooms for people that cross disciplines, right? Maybe you can go to the econ meetings and try to hang out with somebody else, but that organization is structured that way, both through scholarship and through membership. So, that's happening. Social determinants rolls off the lips of many, many people, even if they don't understand it as deeply as maybe we wish they would. So anyway, there's been progress there. I'm optimistic about that direction.
I would say I don't teach in the classroom anymore, but I do some mentoring. And one of my recent mentorees is MD MPH degree that she was getting, and she was doing a study on food insecurity and writing up a paper on that. So it wasn't in this narrow medical model or even real narrow public health model. It was really broadening into this broader social determinants of health or factors that are related to health.
I used to teach, actually, I told you I taught that Evans and Stoddard paper even before it was published in draft. And I was doing a distance education program for physician executives and nurse executives mid-career. And they had to read that. And I'll never, and that was quite a while ago, but for clinicians, the idea that it's more, I'll never forget a cardiologist on the phone, he hung on the phone afterwards and he said, we need to talk about this. He said, I'm 43. I'm a successful cardiologist. I'm a medical director. I didn't know anything about this, about these other things that make people healthy. How can that be? So, there's still opportunities, particularly in medical education, for the breadth of that, but it's a lot better than it was. Evans and Stoddard for me should be required reading for every medical, nursing, and econ and social student. I'm hooked on that. It was an epiphany, and it can be for others.
So I think the one thing, and I think this is reflected in Dave's career. I think, Dave, when you wanted to do a clinical rotation during your residency in a community health center, and his leader refused for him to do that and have it be counted. So we should be encouraging people to get out into the community. I don't know, Dave, you want to add any more to that story? That stuck with me.
It just was my chair of pediatrics at the University of Chicago, terrific guy, but that wasn't legitimate residency experience. So I went off to the South Bronx and changed my life. So thank you very much. But yeah, things have changed.
Great. Well, we have just a few minutes. I'll ask one more question, and to the extent that that you can answer such a big question in a small amount of time. But what about the political will in order to make these changes? Sani, as health commissioner, and your engagement with legislatures, did we really see policymakers comparing two potential programs and asking, which one is going to have the greater benefit, or is it a lot more messy and complicated? One of our audience members put it in the context of Medicaid expansion. There's clear evidence that Medicaid expansion has better outcomes for the residents in a community, and yet there are still states not doing that. How do you factor political will into these questions?
And I think that's one of the things that Kansas Legislative Health Academy was trying to do. How do you bring together people of differing political opinions and respect their political opinions and their different values? I mean, the word freedom can be taken in so many different ways, depending on the perspective that you're coming from. And so I think we shouldn't give up on a key aspect of our democracy of bringing people together to work for the good of our people, our residents and citizens in our states. But it's as people say, policy making is like sausage making. It's messy, but I think combine the technical and the adaptive skills that we need, I think we can make progress. I'm going to continue to be an optimist.
And we could have a whole nother session on this. I mean, it's a great question, but I mean, I think it's really important to focus on that. I mean, I've done a fair amount of writing on political common ground, improving population health, given the political complexities of today, even worse today, but always the political issues. I don't believe that improving health needs to be as divisive an issue as many of the other ones that are more culturally tied, to people's values and beliefs. And I think they're looking for ways to overcome that and to understand people's values and to see how being healthier it connects to those values. I think that's a great opportunity for the future.
Great. Well, that's perhaps a wonderful place to wrap up. I want to thank everyone for joining us today, and we are very grateful to you, Dave, John, Sandy, for taking the time to talk with us. Thank you as well to Debbie Boylan and Sarah Kolk, as well as the entire Health Affairs Forefront and digital teams for making this happen. If you liked this Lunch and Learn, visit healthaffairs.org to sign up for other upcoming events, join our email list to hear about them as soon as they're announced. And I also encourage you to listen to our selection of podcasts, including a Health Odyssey, where our editor-in-chief, Alan Weil, interviews leading health policy researchers and influencers. Health Affairs has a whole new slate of events this month that might be of interest to audience members. I want to mention a few of them. On Tuesday, April 12th at 3 p.m. Eastern, we will host our next Journal Club about an April paper titled Unequal Housing Conditions and Code Enforcement Contribute to Asthma Disparities in Boston, with author Evan Lemire of Harvard University's T.H. Chan School of Public Health. On Thursday, April 14th at 1 p.m. Eastern, Health Affairs Forefront editor Chris Fleming will host a Lunch and Learn with contributing editors Katie Keith and Tim Jost for a discussion on the ACA at 12. They will be joined by Rodney Whitlock of McDermott Consulting. So register for those events and learn more about event sponsorship opportunities at healthaffairs.org. And thank you again, everyone, for joining. We're thrilled to have you and look forward to seeing you at the next event. We're adjourned.